Hi. Hi, this is Mikisha Longie. I am doing my presentation on using personalized reminders and education to address delayed immunizations from Maryville University. My committee members are Dr. Jessica Bland, Dr. Jennifer Brunworth, and Crystal Allery, MBA, BSN, RN, from the facility in which I did the study. Background and significance. Does vaccine-specific education and personalized reminders with the caregivers improve immunization rates in toddlers aged 19 to 35 months? Explore personalized education and reminders on immunization's impact on the immunization rates, and increase vaccine safety and efficacy awareness with caregivers of toddlers. So the purpose of my DMP project was to determine if the use of personalized vaccine reminders and vaccine-specific education increased immunization compliance rates. Delayed immunizations lead to increased risk of acquiring a preventable illness in children. Vaccines may help stop childhood illness from those diseases that are preventable. So as far as the personalized education and reminders that I used, so each of the patients were looked up using a retrospective chart review. The immunizations that were due for each of these patients were included on an instruction education sheet, and the vaccine-specific education for those vaccines were sent to the caregivers of the toddlers. And my hope was to increase the vaccine rates and efficacy awareness of the vaccines. Review of the literature. I used 13 articles to review the literature. 3 main themes were developed through the review of the literature. Those were socio-demographics, which included low income, family dynamics, formal education, and a lack of available resources contribute to lower vaccine compliance. So what I found in the literature are those families that come from a background that have less money, they also have less compliance with their health and vaccines. The family dynamics that I'm speaking about are children who come from single parent or from homes where the families have been split due to divorce. Formal education would be that some may have a high school diploma and some may have dropped out before they even had a high school education. So we're dealing with some people who may not have the education and ability to understand what is being presented to them and the importance of some of their health perspectives. Barriers to vaccine include a lack of knowledge on vaccine safety and efficacy, personal beliefs and fears of caregivers, social media anti-vaccine campaigns, lack in access to services can interfere with immunization status. So what I found in a literature review, like I mentioned before, lack of knowledge on the vaccine safety and efficacy. So what I found is that some of these caregivers of the toddlers do not have the educational background to know what vaccines are for and what they actually do for the patient. Some may have personal beliefs and fears. Some of the personal beliefs are that they do not want to get their children vaccinated because they believe it may cause autism or some other form of disability for the child. Their fears would be that the child would develop autism or some other type of physical disorder. There are social media anti-vaccine campaigns out there, and we also have some of our state representatives actually pushing these anti-vaccine campaigns. So with the main thing that I'm thinking about right now is we have this measles outbreak, and it started in a child who was not vaccinated because the parents did not believe in vaccines. So those are the type of things that we speak about when we say that there are childhood illnesses that can be prevented. Measles is one of those that can be. Lack of access to services. Some parents, caregivers work 8 to 4:30, and that's also the time that the vaccine clinics are open. So they may not have access to bring their child to get vaccinated without taking leave from their jobs. And sometimes this isn't easy for some people because their jobs may not let them take the leave that they need to get their child vaccinated. Also, there are some daycare providers out there who will not take a child into their care if they've had vaccines within the last 24 hours. So that's also a barrier. Communication, lack of communication, incorrect demographics, and social skills of caregivers lead to delay in immunizations. So as far as lack of communication, sometimes the caregiver and or provider do not always speak to each other about what is being done that day. So sometimes a child may come to get vaccines and the child may just get the vaccines without any type of education or reasoning why they are there. So that is something that may be a barrier. Another one is incorrect demographics. So many times when a child comes in, they are to have their number and their address updated by the people that are checking them in at the admissions desk. And a lot of times this may be missed or inaccurate information is given to the facility. So this comes as a barrier because you're unable to reach these children and caregivers because of the incorrect demographics. Social skills of the caregiver. So that would be where sometimes we do have caregivers who may suffer from social anxiety or different things and they just want to get the visit done as quickly as possible. So they may not be actually speaking with the provider about why their child is there, or maybe the education is offered and they just don't want to hear it because they want to get out of the facility as quick as they can. So the theoretical framework that I used was the help belief model of behavior change by Erwin M. Rosenstock, Godfrey M. Hochbaum, S. Stephen Kegels, and Howard Leventhal. So the components of the health belief model are perceived susceptibility, perceived severity, perceived benefits, cue to action, and self-efficacy, and that's taking charge on it yourself. So when we look at this, what we can decide from this theoretical framework is that immunization rates can be influenced through health-seeking behaviors with education and reminders. The individual's understanding of the risk of the health problem and the actions that can be taken to reduce that risk can be changed whenever you use education with the caregiver about that specific disease or disorder that may be prevented and the possible implications of not getting their children vaccinated. This may help to influence their decision to vaccinate. The provider must ensure that accurate information is relayed to the caregiver to prevent potential miscommunication. So when we look at these different aspects of the model, so the perceived severity, the caregiver may not be aware of how severe it is to not get your child vaccinated. That's something that the education may help with. Perceived susceptibility can be described as the personal belief that the health condition is actual and can develop in the child. Immunizations are used for the sole purpose of boosting immunity to prevent diseases. Education with the intent that those individuals are not covered from development of possible preventable illness is essential. And then when we move on, when we look at the perceived benefits, so they may not be aware that the potential benefits of the vaccines for the children. This may give them motivation if you let them know that by getting a vaccine that is relatively safe will prevent their child from being severely ill. This may help persuade the caregiver to get their child vaccinated. Cue to action. So that is when the patient gets all this information and they make their decision. And the self-efficacy, of course, is wanting to help get their child vaccinated and safe. Methods and design. So the methodology that I used a retrospective chart review of the electronic health record of these children. I used pre-intervention and post-intervention quantitative study. The pre and post-intervention of the up-to-date immunization status is shown here, as you can see in the table that I have put up for you. So 77 children were used pre and 77 children post to do my study. As you can see on the table here, on the first day that I collected the data, none of these children were up to date with their immunizations. Those were the children that I was seeking. Day 40 is the day when I went back in after I sent out the education and reminders to the parents that were personalized. And as you can see, I do have a lot more children in there that came in and got their vaccines. So you can see that it does work whenever you do this type of education with the parents. So the design that I use is, like I mentioned before, I sent out a personalized letter to the parents of these children, and it included the safety information of the vaccines and any potential harm that may come to the child if they're not vaccinated. My samples, the inclusion criteria included those that were 19 to 35 months old. They utilized the facility with an active chart. They have been seen once in the past year at the facility, and they are enrolled members of the Native American tribe. The exclusion criteria I have is they are outside of the prior mentioned age range, which is 19 to 35 months. They do not have an active chart at the facility. They have not been seen at the facility in the past year, and they are not an enrolled member of the Native American tribe. So I use this inclusion and exclusion criteria on the 154 electronic health records that I use for the project. And my steps that I used were to find the children aged 19 to 35 months at the facility that were currently delinquent with their immunizations. Then I composed the intervention reminder letter for the caregivers for those children. I found the proper vaccine information sheets for those children that were aged 19 to 35 months. I mailed the immunization reminder letters with the attached vaccine information sheets to the caregivers of the identified children. The necessary immunization data will be collected on data collection sheet to achieve the goals of the project. I stopped the data collection process when I found the 154 charts, 77 pre and 77 post that were used to complete the project. The data collected was examined to determine whether the use of immunization reminder letters with vaccine information sheets increased the number of children who are current with immunizations per the Center for Disease Control and Prevention's current immunization schedule after the 40 days. And I also used the Plan, Do, Study, Act worksheet during the process, and I did share this with the QAPI risk manager for their use in further QI projects. The data analysis, I did use descriptive statistics, the difference between two proportions, the z-test for the difference between two proportions, nominal data, can a single variant affect the test result of two proportions, and to test the null hypothesis. The chi-square was used to analyze the data. So what we found here is that the z-test was used to determine the data variability using binary variables because there are only two possible outcomes for the test. So either they're up to date or they're not up to date. The z-score used the total number of individuals in the study as the denominator. The numerator is the results of two samples in the study. The confidence level of the test is 95% with a confidence interval of 1.96 standard errors of the difference between two proportions. The study size included 77 toddlers in a pre-intervention group and 77 toddlers in a post-intervention group, which equaled the 154 charts that I used. The expected variable was adequate due to the sample size being equal. As you can see here are my results on my analysis post hoc computed perceived power. So the p-value is less than 0.0001 and is less than the significance level of 0.05, there is sufficient information to suggest an increase in the ratio from pre to post intervention. The confidence interval suggests the true change in ratio from pre and post intervention. Since 0 is not included in the interval, we have significant evidence to show a change in one direction. The achieved power of the study is 1.0000, which is considered high in strength, and we had a 65% improved immunization rate whenever we analyzed the results. Here I have my pie charts, which show the pre-intervention, which is no is not up to date, and yes is up to date. So we had 100% of those toddlers used that were not up to date with their immunizations. Post-intervention, we had 65% that were up to date with their immunizations and 35% that were not up to date with their immunizations. The limitations: I had inability to provide immunization education to all toddlers with active charts in the facility, limited time, which limits the number of toddlers used in the study, and the results lacked ethnic generalizability. So when I talk about not being able to provide education to all of the toddlers with active charts in the facility, like I mentioned before, I used a small group of the total proportion of toddlers that were aged 19 to 35 months for the facility. If I would have used more of these children in the study, I may have found a different result in the end. Limited time, which also equal to the limit number of toddlers used in the study. So given a larger time frame, more charts would have been able to have been reviewed, and potentially a higher number of toddlers would have been reached, and we would have had a higher compliance rate. And I only used Native American subjects for the study. If I would have used other groups of ethnic backgrounds, the results may have been different, but the purpose of this study was for this facility, which provides care to the Native American population. So my discussion: does vaccine-specific education and personalized reminders with caregivers improve immunization rates in toddlers aged 19 to 35 months? So personalized immunization reminders and vaccine-specific education do improve immunization rates, and we can see that with my 65% increase in my post-intervention data. Personal beliefs of caregivers can change with proper education. So some of those caregivers who may have been in the group that feared getting vaccines for their children, or may have been against vaccines initially, may have changed their minds and brought their children in to get their vaccines. That was not studied for the specifics to see why the children were not vaccinated, but I am sure that that had to do with some of the reasoning. Implications for practice. So implications for nursing practice: immunization rates can improve with proper communication. Personalized vaccine education should be used to increase vaccine awareness. So the nurse caring for these children, at every visit, they should be speaking with the caregiver about the immunizations of the child, if there are any immunizations due, and the reason why we like to give these immunizations based on a specific schedule that was generated by the Centers for Disease Control and Prevention. Implications for future research. Policies should be updated and reflect current research methods. Increased funding to support immunization education within the facility, and staff education on importance of education on immunizations at every visit. So the current policy at the facility does not have its specific that personalized reminders and vaccine-specific education should be used as a routine part of care with immunization practices at the facility. So if that were changed to include this, they may see a higher rate of vaccine compliance. Funding is lack in many areas. So many facilities do not receive that proper funding that is used to further educate their staff on the importance of vaccines. So it's up to the nursing educators of the facility to ensure that their nurses know the importance of vaccines and know the proper vaccines that should be given within certain time frames of this child. And as it was mentioned, the importance of education on immunizations, education at every visit. So there have been, when I did my chart reviews, I have found that there were some educational opportunities that were missed or missed vaccines altogether. There was nothing documented within the chart that education had been provided or that the parents had refused vaccines that day. So this is considered a missed opportunity. Those missed opportunities can equal a significant amount at times, so it's up to the providers to ensure that we are using all resources available to educate these caregivers about immunizations and their importance. So in conclusion, statistical evidence supported using personalized reminders and vaccine-specific education with caregivers of toddlers aged 19 to 35 months increased immunization rates. Education can be tailored to fit the needs of the caregiver. Encourage immunizations and educate at every encounter with patient and caregiver. These are my list of references that I used for my study. And thank you for listening.